Now for Professor Ahmed Barsoum.
Okay. Okay, thank you everyone for inviting me. Actually, I was told to give a presentation about palbociclib. It's really hard to give a presentation about palbociclib in 2026 because of, we discussed CDK4/6 inhibitors for many years now. We moved from the metastatic setting to the early setting, so I tried to dig deeper and try to go a little bit in behind the scenes to try to find some solutions or maybe some answers about the overall survival benefit seen with ribociclib versus palbociclib. So let's start. These are my disclosures. Are we underestimating palbociclib? So let's go for what we know first. This is a table showing the benefit of CDK4/6 inhibitors in the first-line metastatic setting along with non-steroidal aromatase inhibitors. As you can see, average of median PFS was 23, 25. We're talking in this part. And along with fulvestrant in the first line, in MONALEESA 3, in 50% of the cases, we have achieved a higher maybe PFS, but maybe we are not using this much of regimen in the first line for aromatase inhibitor naive to save fulvestrant maybe for the second line. And we have seen the success of CDK4/6 inhibitors as well in the PFS benefit in PALOMA 3, MONARCH 2, as MONALEESA 3. As you know, we are talking in the 10 to 15 months of PFS. However, the overall survival was not the same between the CDK4/6 inhibitors. As you can see, the MONALEESA trials beat PALOMA trials and maybe MONARCH sometimes in terms of overall survival. As you can see, the three main trials of ribociclib showed the better overall survival than the other CDK4/6 inhibitors. So maybe there is something to explain to us why is that. So question number one, are we really giving CDK4/6 inhibitors for all eligible patients in real world? This is like data that was surprising to me when I was presenting this, when I was preparing this presentation. In the US, real life percentage of patients actually receiving CDK4/6 inhibitors in 2018 was published, and it showed that it's much less than we know. This is an analysis in 2024, like a more recent one. It showed that in USA, 66% in 2024 Medicare analysis showed that no more than 2/3 of eligible women receive CDK4/6 inhibitor for different reasons. Maybe fear of toxicity, maybe no access to the medication, maybe the clinician doesn't seem to be convinced with the CDK4/6 inhibitor in the first line. So we have seen a lot of women eligible but not receiving it. We have a 10,000 out-of-pocket cost can be substantial. It's, it's in Egypt as well. It's still costly to go for out-of-pocket. In Europe, maybe a little better, but still, it's not 100% of eligible women receiving the treatment. In Middle East and Africa, actually, it's better than we thought because Middle East includes the Gulf countries and Egypt as well. In Africa, we have seen around 64% of eligible patients receive those kind of treatment in the first line. This is the main and one of the most important point. Palbociclib still to the date, still the most widely used, despite the data of MONALEESA, despite many data showing that maybe ribociclib can be the better one. So the historical dominance is still visible till 2024 databases. As you can see, palbociclib is dominated around 54 to 64% of use. So that was a brief about what we know in real world. Question number two, PALOMA 2 trial in the first line with aromatase inhibitor. It's a study to measure the efficacy of palbociclib with aromatase inhibitor in the first line. This is the trial, including the postmenopausal women, ER positive, HER2 negative, no prior treatment, letrozole versus letrozole plus palbociclib. What about the patient selection? In PALOMA 2, did it include some patients with partial resistance? This is a very important point. Could that affect the efficacy data? Let's explain the endocrine resistance criteria first. As you can see in the adjuvant setting, we are talking 5 to 7 years. Those patients who relapse in the first 5 years and 1 year extra and after stopping the adjuvant are called early relapsers, endocrine resistant. And those who relapse after an extra year of endocrine therapy are called late relapse and they are called endocrine sensitive. 40% of the patients are hormone sensitive in this PALOMA-2 trial. 40% only are hormone sensitive. 38% are hormone sensitive as well and de novo criteria. So these patients should get benefit from this regimen because they are hormone sensitive. They are past AI or never received AI. However, we have almost quarter of a patient, we are talking 22%, less than a quarter of patient. They are early relapsers. They shouldn't have received AI in the first place because they progressed within the first year of adjuvant therapy. So almost quarter of patients were AI resistant already. So that may alter maybe the results of the trial. As you can see, this is the table that showed the numbers that I just showed, and around 12 months from actually finishing the adjuvant therapy, we have 22% of the patients receiving this regimen. So, making almost a quarter of the population more aggressive than all patients were endocrine sensitive. You understand my point? Because this finding was not there in the Mona Lisa trial and the Monarch trial. Now we are going to the question number 3 in Mona Lisa 2 trial, a very comparable trial that we cross-compare always for the overall survival. However, we don't cross-compare when we discuss the patient criteria and the patient selection. How many patients included were secondary hormone resistant? They shouldn't have received AI. As you can see, there were 0% because the inclusion criteria of the Mona Lisa 2 trial were de novo breast cancer or relapsing more than 1 year. So they had 22% of the patients better than those started the PALOMA trial. So the answer is 0%. Only highly sensitive patients were allowed to go into the Mona Lisa trial. So another point that we don't discuss much is CNS metastasis along in hormone positive HER2 negative patients. In the PALOMA-2 trial, it didn't exclude all the patients with CNS metastasis. It was one of the findings found in metastatic setting. And it was allowed, when controlled, it was allowed to be included in the setting. As you can see, CNS metastasis significantly worsened the prognosis in ER-positive, HER2-negative patients. This is a part of literature, like the incidence of brain metastasis is 15% among hormone-positive, HER2-negative, and the prognosis is very poor. As you can see, the median PFS, or median OS of them is around 9.4 months versus without brain metastasis around 26 months. I'm highlighting this because I want to show you how bad of a prognostic finding if patients were found to have a CNS metastasis in hormone positive HER2 negatives. There is a huge difference in survival of those patients. So the inclusion of those patients or acceptance of presence of those patients in the PALOMA trials maybe have affected the outcome in terms of overall survival. As you can see, the PALOMA trial, they exclude only those uncontrolled CNS metastases, but allow those who controlled CNS metastases. If you go to the Mona Lisa trial, CNS metastasis as a whole was excluded from the trial. Another point, point number 5, what about liver metastasis? Even liver metastasis, patient selection was different between those trials of CDK4/6 inhibitors. Did the Mona Lisa 2 and PALOMA 2 had the same percentage of liver metastasis at the study start? The SEER database reported that the median overall survival for patients with liver metastasis was approximately 14 months compared to 26 months. It's very similar prognosis to those with CNS metastasis. Having liver metastasis is a very poor prognostic finding. If you see the PALOMA 2 trial, we are talking around 38% if you take the average between those in the placebo arm and the study arm. We are talking around 38%, almost 40% of the patients have the liver metastasis. But if you go to the Mona Lisa trial, we are talking visceral metastasis around 60%. However, those with liver metastasis, as you can see here, we are talking 17 to 21%. We are talking half of those patients had liver metastasis. What does that mean? It means that we have a better profile of patients going into the other CDK4/6 trials when we compare them to the Paloma trials. Another point, question number 6, Paloma 2 showed PFS but no overall survival as we discussed. Did it fail to show that same overall survival benefit in real world data? And actually it didn't, because the trial showed the PFS benefit and it failed to show the overall survival benefit in the trial. However, the P-Reality X, it's a retrospective observational cohort study, around 2,800 patients included in those patients, included for palbociclib. And it's actually a bigger number than the study design, than the study itself. And it was very comparable between the two arms. And as you can see, the PFS benefit was seen little bit less than that of the trial. However, there was an overall survival benefit, as you can see, not like the trial. We are talking 5.9 months of absolute difference. This was seen in the real world data, not in the trial itself. Question number 7, or point number 7. In second line, post-AI, along with fulvestrant or Wilserd, MONALEESA 3 and MONARCH 2 excluded patients who received chemotherapy for advanced setting before before the study start. They excluded any patients who were in visceral crisis, for example, and received chemotherapy upfront before moving to the CDK plus endocrine therapy. They allowed only one endocrine therapy for advanced setting before that, like AI followed by fulvestrant and the study design. What did Paloma 3 trial allow? Actually, it was a mess. If you go deeper in the Paloma 3 trial, it allowed a lot of patients to receive chemotherapy, a lot of patients to have received different lines. So it had the probability of having a poorer prognosis patients. Maybe that affected the overall survival. As you can see, the MONALEESA trial, no prior chemotherapy for advanced setting. And the MONARCH 2 trial, same, no chemo for MBC. However, the Paloma 3 allowed one prior chemotherapy regimen for advanced cancer. Are the percentage of patients small or large? Let's see that. It's around 30 to 36% of patients receiving chemotherapy in the metastatic setting. They are very poor prognosis patients. They should have started chemo before the endocrine therapy. And in the end, we discuss and we compare overall survival between those trials. They are not the same. As you can see, this is like a table comparing the trials. As you can see, around 34% were permitted to have received chemotherapy before, and they also permitted any number of endocrine therapy before moving to the fulvestrant plus palbociclib. This is the Annals of Oncology in ESMO-like publications showing that approximately 75% of the patients enrolled in the Paloma 3 had received more than one prior line as a systemic therapy for ABC, advanced breast cancer, and 1/3 prior chemotherapy, as we discussed. This renders Paloma 3 trial as a whole new different study than MONALEESA 3 and MONARCH 2, totally different patient population. In terms of PFS, we have seen the benefit. In terms of OS, we didn't see the difference. We see that MONALEESA trials and MONARCH trial have the better OS benefit. However, the Paloma, maybe because of the things that we just discussed. However, in terms of PFS, we have seen the benefit was very comparable. Still, there is a hazard ratio of 0.5 versus 0.55 versus 0.56. So we have the same 50% benefit in terms of PFS. Moving to point number 8. In second line, palbo plus fulvestrant in the Paloma 3, there was no overall survival in the sub-analysis of those 34% who received chemo. Why this is a very important point? Because one might say that why does having to receive chemotherapy before moving to fulvestrant plus CDK affect the survival? Maybe they benefit. No, this actually data showed that those who received chemotherapy didn't show the benefit from adding palbociclib with fulvestrant, meaning that this affected the overall population in terms of OS in the end. As you can see, with prior chemotherapy, the benefit was not there. So the 34% who didn't benefit from palbociclib with fulvestrant, they affected the whole population and affected the end result of the Paloma 3 trial. So, my take-home messages: cross-compare trials is liable to bias, especially if you don't dig deeper in the trial itself. Paloma 2 trial included more aggressive population than most similar setting studies like Mona Lisa 2 and Monarch 3, which could be related to the lack of significant overall survival benefit. The real-world data showed overall survival benefit despite the lack of this finding in the trial. Paloma 3 trial definitely included much more aggressive population, which in some expert opinion should not be included in a study like that. Thank you so much.
Thank you, Dr. Ahmed.
Laugh.
Your analysis for this misleading criticism surrounding the palbociclib regarding the overall survival is really and extremely appealing. Thank you.
Thank you.
It's different type of culture of lectures. Thank you.
Thank you so much.
This was our last lecture today. Thank you all for being with us, and see you tomorrow, inshallah.